Thank you for this introduction. So this is a challenging talk because most of it is wishful thinking in the future. But the bottom line is that the future is bright as far as interventions are concerned for endovascular treatment of aortic stenosis. I do have a conflict of interest, and this is I'm a consultant for Excision Medical, and we'll talk a little bit more about this particular detail. So what is the current status as far as TAVR is concerned, and what are the estimates and predictions for the future is concerned? Approximately 130,000 TAVRs are being done annually in the United States, and this number is growing every year. And as far as future estimates are concerned, in 10 years from now, there will be 535,000 TAVRs per year performed in the United States. So this is a staggering number, quite impressive. And at least 200,011 valve-in-valve procedures will be done, which is a huge, huge number. And at least a third of those will require leaflet modification procedures. Now, there are certain valves that will require this more frequently, such as short frame. Redos might be benefiting in leaflet modification procedures in about 25% of cases. This is just a rough estimate. But a tall frame, it is estimated that they will benefit from leaflet modification procedures in 75% of cases for a variety of reasons, and this the time doesn't allow us to go into details. But what are the potential risks as far as TAVR is concerned when you do valve-in-valve type of procedures? One is coronary artery occlusion, which is the most concerning, most frequent type of a scenario that we have to deal with. Another one that's very important is poor hemodynamics from underexpanded valves. And this is particularly more common in patients with severe calcifications, such as seen in patients with bicuspid aortic valve, with type 1 and 0 type of bicuspid aortic valve. But the reason for it is non-circular expansion that not only leads to a shorter durability of the valve, but also to a certain degree of perivalvular regurgitation. Now, going to the topic of aortic valve leaflet modification, there are two techniques and technologies that are available, actually more technologies, but two techniques available. One is laceration, or you would call it splitting, or division of the existing valve. And here are four of them that are currently either being used or being investigated, such as Basilica, Cleve, Unicorn, or currently by Transmural System Company, Shortcut by Picardia, and SolarF by Excision Medical. And then more aggressive type of approach is actually excising part of the leaflet, or the whole leaflet, or actually the whole valve, which might address the issues of what Dr. Atkinson was talking about as far as too small annulus in existing valve to resolve the problem and avoid complications related to too small valve and mismatch, PPM. So excision devices are a cathedral, and a splitter by HDV Medical, and Viking with a temporary so-called HemoShield valve by Excision Medical. We'll mention a little bit more about it. So Basilica was the first one. This is a publication in 2018, which is one of the earliest ones. It uses electrocautery 0.014 wire with a stiff end actually being used to cross the valve, and then a snare that's placed in the left ventricular outflow tract, and it's snared, and then basically just the valve can be splitted either mechanically or using electrocautery. And the clinical trial or registry has been carried on, as you can see here with information, in significant number of patients and centers, and those were all very savvy, useful, experienced operators that had a very high technical success rate in the upper 90s and a relatively low incidence of vascular or hemodynamic complications. Now this has evolved a little bit further where a transmural system company has actually designed a so-called telltale wire for using basilica that uses electrocautery to be able to split the leaflet. Now, another modification of basilica is so-called cleave or unicorn that uses radio frequency ablation and balloon-assisted leaflet laceration or splitting, as you can see here, placing different sizes balloons going from the smallest to the largest to resolve the problem. And this has been used actually a little bit more frequently nowadays, but again, it's just a modification of basilica. Shortcut by Picardia is a mechanical, literally mechanical leaflet splitting, as you can see shown here. And from the clinical trial, this device has been approved for clinical use for the last 6 months or so. And it has a pretty high effectiveness either on short-term basis at the time of the procedure, also at 1 month, and also at 3 months, and relatively low incidence of complications and the risk of occlusion of the leaflet or any other adjunctive procedures that might be needed. Now, cathedral is a leaflet excision, so now we're going to the excision by electrosurgical debulking using existing devices. It's actually a modification of basilica using electrocautery and removing the leaflet, as you can see here. Obviously, there is a certain risk involved in those type of procedures because there might be a lot of calcium and debris present in the leaflet, and some of it could embolize. So the incidence of embolization is slightly higher when you do those type of procedures, and you might need a protection device in this type of scenario. Splitter, which is within a category of excision, but it's really a very narrow excision, and but the name is splitter. Anyhow, and it's a device that, again, is not commercially available. It's currently undergoing a certain evaluation. It's using electrocautery wire to be able to anchor to the leaflet in the desired location and remove it. All of the devices have certain deficiencies in addition to what I've already mentioned to be able to enter in the exact place where you want to actually achieve separation or splitting or incision or excision of the device. So you really need a catheter, a guiding catheter that will guide you exactly to that particular location. And hopefully you'll avoid also calcium, because that is probably one of the major detriments and risk of not being able to cross the valve leaflet, but also risk of embolization. So this is where Excision Medical is unique in a way, and this is really what attracted me about 4 years ago to get involved a little bit deeper in with this device. It has really proprietary stirrable catheters for every single leaflet where you can adjust the entry with a catheter to the desired location. And in addition to that, it has a very unique, very interesting temporary valve that you place just below the valve that you are going to excise or incise. And that protects you from aortic insufficiency. You could literally remove all 3 leaflets in a patient that is fully compensated for about 80% of the flow is forward, and only about 10 to 15% is retrograde or aortic insufficiency. So this, I think, offers us an opportunity not only to make a bigger opening and prevent those obstructions to the coronary, but also, as you can see, there is a significantly larger excision or removal of the valve where you can put a equal size valve later if needed. So I think this will be the future, in my opinion. So in conclusion, the risk of coronary artery occlusion, particularly for bicuspid aortic valve and valve, can be prevented with leaflet modification procedure that exists at the present time, and even more so in the future. Pre-TAVR leaflet modification procedure may optimize TAVR, particularly in calcified valve and in bicuspid aortic valve that are challenges, by reducing ellipticity and offering better valve expansion and offering, therefore, using larger TAVR valve for valve-in-valve procedure, and reduces the risk of annular rupture because you don't have to be overly aggressive. However, the future clinical evidence definitely is needed to validate whether splitting or excising of native or SAVR or TAVR heart valve or prior to valve-in-valve procedure is of a benefit. I hope you heard the last comment. Thank you.
All right, guys, we're going